Okay, you can start.
Yeah, right. So, good evening to all those who joined. Today, we are going to be talking about shadowboxing, and shadowboxing is nothing, but we are going to discuss a case. This was a case that was managed majority of the part by me. Initial part was managed by another JR. The final thing was managed by some other JR. So, we are going to take the case as a whole, and we are trying to see where I made mistakes or where I could have improved upon managing the patient. And even after seeing, even after I went through the case also, I myself am not sure regarding the final diagnosis that the patient has come to. So what are we going to learn from this? We are just going to learn from whatever mistakes I have done and some learning points that goes along the way. And I'm very happy that Mehul sir is also here because he can point out some of the things that might not be happening here also. That might not have been picked up by other people as well. So here we are going to go through the case. We're going to take short breaks in between. And this break around 30 seconds to 1 minute, wherein each one of you will have to think how you would have managed this patient at this juncture of time. And then I will go on to discuss how I managed the case. And if there are any filling defects or something that you don't understand, you can come ahead and ask us the doubts. Some other differential that you would have given, some other approach you would have taken to managing the patient. We can discuss this. And basically, that's how you improve your clinical skills. And I hope it makes sense. And each of the segment, we are going to divide it and we are going to call it aliquots. So we are going on over to the first part. Here is the case that is beginning. And this part was not seen by me. It was seen by another JR. And we are talking about a 69-year-old male patient who was rushed into a resus bed. Right, he was in EM1. He was taken right into a bed. And by now, all of you might be knowing what is the first thing that we do on seeing the patient. We go and do the primary survey. And here you can see that the primary survey, the airway was patent. The patient had a respiratory rate of around 20, saturation on the 94 to 95 mark. A circulation which showed a heart rate of around 180 per minute. By that time, some monitors are being connected, which shows like a rate of around 140, 180. Initial BP recording of around 150, 80. You assess the GCS of the patient, it is E1, B1, M1. You go and do a rough check of the pupils, and you find that the pupils are equal and reactive to light. Sridevi ma'am, hi. And finally, I just touched the patient briefly, and the patient was like at least febrile to touch at that point of time. Now, we take a break here. We want you guys to think how you would have managed the patient going forward, and each of the step has to be told. If you are putting an IV line, you're going to say you're going to secure an IV line. Your water samples you want to send at this point of time. How are you going to manage the patient? Even if it is attaching monitors, you're supposed to say, I'm attaching the saturation probe, I'm attaching the BP cup, I'm attaching the oxygen mask, I'm attaching the ECG monitors. You have to see each of them in detail. Because sometimes we feel like we might be doing these things, but when it comes to real life, we actually forget to do these things. Unless we practice it 1,000 times in our head, we are not going to be performing it when the time comes. So here we are going to take a break of around 1 minute or 30 seconds. Think how you would have managed this patient, and we'll come back.
Vishnu, while people are thinking, I just wanted to add one thing.
Sir, please.
Just related to primary survey in general. So I think one of the things that juniors make mistakes is that they assume that primary survey is just about looking at the monitors. But you have to add some clinical examination thing to
yes.
this as well.
Yes. Which is what I wanted to highlight here as well.
Because when you're saying heart rate, BP and all, it also includes looking for the peripheral pulses, capillary refill, peripheries are warm or cold. Similarly, breathing it's not just you look at how work of breathing guys say, and all of those things. So it's not primary survey doesn't mean that you're not actually examining the patient and you're just looking at the monitors. So I just wanted to highlight that. I think you can start by asking one of the first semester.
Right. I'm not. The screen is not like not being seen by me, sir. You can call any of the first semester and we can talk to them as to how they'll manage.
Okay. Siddharth, you want to try?
What else do you want to ask me regarding this case from this primary survey? Do you want to know specifically anything?
Siddharth, you can start.
So, based on the primary survey, the patient appears to be unresponsive. So, first thing I'll see is his random blood sugar, and then look at securing the airway because the patient is unconscious, and I'll attach a BP monitor. I'll get an ECG done. In the meanwhile, I'll also get an ABG done after securing a cannula.
Right. So anything else other than ABG you want to send at this point? Or just an ABG would be fine?
Currently, an ABG would be fine.
Right. Anything else that you want to know?
People's equivalent reactor yet. Any like how was the patient brought? I came in between, like while you're explaining about the case.
This is all that there is. There is nothing else to add.
There's nothing else to add.
Yes,
Any antecedent history?
No. This is the primary survey we are talking about. This is immediate thing. You do not go on to take a history. You can, of course, take the history when you have lots of people with you. But here we'll have to stabilize the primary survey before we go on to the history or whatever.
So I'll secure an IV line. I will do an ECG. That's it. Since the patient is unconscious, I'll think of securing the airway also.
Right. So, is there anyone else? Is there?
Hello.
Right. That's it. That you're done. I'm just asking myself, sir. Sir, anyone else is there among the first semester, second semester?
I think Bharat is there. Dr. Bharat, do you want to say something?
If not, Mehul sir, you can ask the questions.
Okay, then Bharat is having connectivity issues or something. Mayuri, you want to add anything? Add anything to what Siddharth said?
Mayuri was the patient. Was the JR who saw the patient first.
Okay, then I think we should avoid asking her then. So I think it's fine only.
It's fine only. So what I would like to say at this point of time is that like sir told, clinical assessment is like so important. You see a heart rate of 180, you know that because the monitor shows that it is a heart rate of 180. You are telling that the patient has a BP of 150 by 80 because the monitor shows it is like that. You do not rely on monitors, you always rely on your clinical exams. This patient might easily have a BP of 40/20. It is just that some erroneous reading of the BP is showing it to be 150/80. So whatever you have to do next is check whether the peripheral pulses are visible or not, whether the patient's peripheries are cold or warm, whether a capillary refill time is less than 3 or not. Severe shock and all, the patient might be having skin mottling and all. So these are the signs that you should be actively looking for and not just rely on a single BP of 150/80 and think that the patient is not hypotensive. This is the first and the foremost thing when you approach this patient. A respiratory rate of 20 per minute. The biggest problem here is we do not sit for at least 10 seconds, look at the patient and see what is the respiratory rate of the patient. Stay for 10 seconds, just look at the respiratory rate, look at the work of breathing. Then you will actually know if there's a severe work of breathing or if the patient is not maintaining adequate saturation. Again, you know whether you have to auscultate the patient or not. A wrong saturation, a saturation of somewhere less than 90 or 80, whatever is shown in the monitor, might not be reliable, especially if the patient has a shock. But I think you can always rely on the highest value that the saturation probe shows. That is, if the saturation probe shows that the saturation is 94, there is high likely that the saturation is 94. But in a deeply profound shock patient, you do not expect the peripheries to be adequately perfused. So it may end up showing a saturation of 40 or 30. That can be erroneous. So even in the primary survey, it is not the numbers. You're always clinically assessing the patient. And I want to bring this point clear and cut to each and everyone that is listening to this narrative right now. If that is clear, we'll go on and I'll just talk about the respiratory rate. He was definitely not tachypnic, no significant amount of workup breathing. Saturation was showing 94, and the 94% was shown with a very good waveform as well, which indicated to me that the patient had he was not actually in shock. I went and checked his pulse. Pulse was very good. So patient did not look hypotensive to me. Capillary refill time was less than 3. Peripheries were warm to touch, at least not febrile or anything. And at this point of time, seeing that the GCS is even V1 M1, I definitely went and did an RBS, which was found to be normal, somewhere around 100 to 200. So this is what you have to derive from the primary survey. And how do you move forward? Airway, nothing to do. Breathing, nothing to do. For the circulation part, a heart rate of 180, obviously you'll have to take an ECG and see. Meanwhile, I am preparing to intubate this patient in view of a GCS less than 8. Does that make sense? At this point of time, if any one of you have any doubts regarding how I managed the patient so far, or if you want any more information to be added to this clinical scenario, you can ask now. Else, we'll move on to the next part.
Hi, Dr. Vishnu. Dr. Sri Lakshmi here.
Please.
So how do you comment that the airway is patent with a GCS of 3?
Exactly, ma'am. That's a very good point. The point being that I didn't see any drooling of secretions. I did not see whether the patient had any threatened airway or any abnormal sound that he was. He was not in any frank respiratory distress as to my clinical judgment. Just based on that, I would say that the airway was patent.
Okay.
It is not like you have a GCS less than 8 means that the patient's airway is bad. That is never the case. Airway is a separate thing. Disability is a separate thing. We have patients who are even V1 M1 maintaining perfect airway as well. It has happened plenty of times as well.
That's a very good question, actually. Basically, GCS was invented for trauma patients. We generally use it for all patients now, but we have to interpret in certain contexts. So there are definitely patients with GCS less than 8 and who are threatened airway. That those patients you need to intubate right away. But there are definitely a lot of patients who are having low GCS. For example, they might be coming with hypoglycemia or something. So, but their airway is not actually threatened. So you have some time to actually figure out what is happening to the patient before deciding on the future course of action.
Yeah. Actually, my doubt was how could you comment it was patent? But not threatened fits better, but patency, how do you comment? Because if a patient is verbalizing, then we would say it is patent. But patient with a GCS of 3 telling patent was a bit confusing. That's why I cleared my doubt.
Okay, that's fine. I think this is just the terminology that we use in our ED. So it's not based on any textbook per se, I guess.
So we are moving on to the next part. We are definitely going to intubate this patient. So moving on to RSI, the only reason I put this as a separate part is there are plenty of FSMs here. So just to highlight on them, if Siddharth can just say what are the steps of RSI? Or Mayuri or whoever is the junior. I don't know who it is.
So there are mainly 7 steps. First part is preparation. We need to prepare. We need to prepare for all the materials required for intubation, like drugs and everything, a blade, ET tube, and everything. Then comes the pre-oxygenation part, which has to be done for at least 3 minutes at 100% FiO2. Then comes the pre-medication. Then comes the placement of the tube. After that, we have to check for the position of the tube also after placement.
Wait, you told about preparation, you told about pre-oxygenation, you told about pre-medication, then what else? Positioning the patient, placement, anything else?
Pre-induction, sorry.
Induction agents. So it comes like that. Induction agents, then you position the patient, then you place the tube, and then 60 ho gaya na? There are 7 agents.
Whether it is or not, and then
the post-intubation care that you provide to the patient. You attach on a venti, you provide the ventilator care bundle and all that. So that comes as a 7th P. Right. And my question would be, what drugs will we be using for this patient per se? Any drugs in your mind? I went with a simple etomidate and rocuronium, 1 milligram per kilogram. I mean, 0.3 milligram per kilogram of etomidate and 1 milligram per kilogram of rocuronium is what I gave. Special considerations not here. I did not think of anything per se. If the patient had been in frank shock, I would have maybe considered to give half the dose of sedative and double the dose of paralytics. But since the patient, as per me, was not in frank shock, I just went ahead and gave the standard drugs as well. So post-intubation, again, the primary survey was repeated, and by this time, the ECG guy came and he had taken an ECG. So if you have, I think it is a very straightforward part over here. If you have no doubts, we can just go ahead with the next part.
1 minute, Tushka. I think we'll ask 1 or 2 other questions. Can you go back to the first aliquot?
Yes, sir. Please.
So we have 69-year-old male patient and monitor is showing heart rate of 180. So, Mayuri, do you think this can be sinus tachycardia?
Sir, 220 minus age, we have to do for the normal sinus tachycardia range. So in this patient, around 150 heart rate, if it is sinus tachycardia, then around 150 heart rate should be there, and it is more than that. So it is not sinus tachy.
Yes, very good. So generally the rule that we use is 220 minus age. That's generally how far sinus tachy can go. Sometimes it may go higher than that, depending on the person and the situation and all. But immediately seeing the scenario, you will be thinking that there is some kind of tachyarrhythmia involved, because it would be very unusual for a 70-year-old to have sinus tachy with a heart rate of 180. Next thing I just want to emphasize that whenever you have patients coming with this kind of GCS, don't intubate the patient before checking an RBS. So it seems like a very obvious thing to say, but you'll be surprised the kind of mistakes that people make at 3 or 4 in the morning when they have not slept for a few days. So these kind of things seem simple, but sometimes they do get missed. So just keep that in mind as well. So Vishnu, you can go forward.
So we have the ECG. Now this is the real ECG of the patient. Now this is the real ECG of the patient after I did something to the patient. I do not want you guys to take this as a heart rate of 150, because what we usually say a heart rate is that you divide 300 divided by the number of big boxes between the RR interval. That is how you roughly calculate the heart rate. This patient, I had done something to the patient which caused the heart rate to come to 150. But just think of this ECG as a heart rate of 180 and comment on how the rest of the things are. Like, just take this as heart rate of 180 and tell me what it is. That's all. Just take this heart rate as a 180 and tell me what it is. Anyone? No one. Mayuri. Chalo.
Yeah, wait. Arushi, you want to try?
Arushi is it. Just think that this is not a heart rate of 150. This is a heart rate of 180. You can comment. You can say that this is a heart rate of 180, and the rest you can just fill it up.
Just be regular to me. Axis is normal. I can't really appreciate the E waves here.
Is the axis normal?
Wait, 1 minute. left axis deviation. Okay.
Some borderline left axis deviation, you could say.
I can't really appreciate the P waves.
Right.
Looks grossly narrow, complex only,
Right.
not right.
So what would you take this as? Regular narrow complex tachycardia at a heart rate of 180.
Atrial flutter.
Okay, flutter. You're not. Are you seeing any P waves?
No, sir.
No. So can it be flutter?
Atrial fibrillation.
Less likely. Fibrillation. In fibrillation, usually the heart rate tends to be more irregular rather than regular. So an irregular narrow complex tachycardia is where you're going to be thinking of atrial fibrillation per se. So what can this be?
Atrial fibrillation with fast ventricular rate.
No, I'm just asking you, if it is a fibrillation, it was supposed to be irregular. But this looks to be more or less irregular. Right. I don't think so. It is irregular per se.
It's not irregular.
So it is a regular narrow complex tachycardia. What are your DDs?
PSVs.
Yeah, PSVT can be one. Atrial flutter can be one. You have your AVRT, AVNRT, what not, and what else. Flutter, no P waves discernible. I took it as a PSVT. Now, Mehul sir, do you have anything else to add to the ECG other than a PSVT? Because this is sort of important when it comes later on in the case.
See, if you're looking at the lead 2,
Sir.
I am seeing some bumps on the end on top of each T wave, which are suspicious for possible P waves. I'm not
suspicious for possible P waves, right?
But looking on V1, I don't see any. Looking at this thing, V1, I'm not seeing any biphasic P waves to suggest that this is a sinus rhythm.
Right. So I gave the benefit of doubt that this is a PSVT. And by this time, his blood gases had also come back and it showed a lactate of just 1.6. So confirming my thing that PSVT, although we tell that there are, how do you manage PSVTs? Basically, you divide it into two groups. You have your hemodynamically stable groups. You have your hemodynamically unstable groups. Hemodynamic instability means that either the patient is having any chest pain secondary to angina, the patient is having any shortness of breath secondary to pulmonary edema, the patient is having shock, cold peripheries, or the patient is having some sort of, let's say, decreased sensorium secondary to reduced perfusion. So if you just look at it, it is a PSVT. It was a patient who was an E1 V1 M1. But I was not satisfied. I did not think that the patient clinically was in shock. I attributed that he was in a E1 V1 M1 status secondary to some other thing. Hence, I took this as a hemodynamically stable PSVT and I went along that algorithm. Now, this I don't know whether it is the right way to manage this patient. I honestly don't know. I would like to just ask Mehul sir or my senior Sridevi ma'am here whether my approach was right or how would you have managed this patient differently. Mehul sir?
This was ECG after you did something.
This was after I did something. I definitely agree. But again, it was like a 180 heart rate, regular narrow complex tachycardia. Sir. The patient was still even V1 M1. Of course, I had paralyzed him by now. That's a totally different thing. But I wasn't satisfied. I wasn't thinking that because peripheries were so good, it was like a very good pulse. Peripheries were warm. There was CRT was less than 3. I thought that even V1 M1 was not secondary to the PSVT. That PSVT it was not secondary to a hemodynamic instability that caused the AMS. I thought it was something else that caused the AMS.
I don't think you are exactly wrong. So, but even if you did decide to shock the patient, it wouldn't I wouldn't say it would have been wrong decision either.
Right. So we are entering the gray area now, right?
This is the gray area. So
This is the gray area. So I took this as a hemodynamically stable PSVT with this patient having AMS for some other reason. I went and first auscultated whether he had any carotid bruit. No carotid bruit. Went on with my vagal maneuvers. Did not work. Gave a shot of adenosine. No response. 12 milligram adenosine. No response. 12 milligram of adenosine. No response. 6,612 is what I gave. So at this point of time, I was really doubtful. Is there something else going on with the patient? I just gave him a shot of metoprolol 5 mg IV to see what happens. And after giving 5 mg IV metoprolol is what I got this ECG, which showed a heart rate of 150. And this was the ECG after I gave a metoprolol of 5 mg IV dose. I just went along the algorithm, and at this point of time, I was like, okay, there is something else that is happening with the patient. Let us just keep this aside for a time being, and let us go on and take the history as to why the patient had and the relevant history and the other details to see whether it fit the entire picture or not. Right. If anyone else wants to add anything, they can add at this point. Or you have some unclear doubts or anything.
So definitely history will help us here. So whether there is any history to suggest the patient is having sepsis or any other reason why the patient could be having this kind of tachycardia
Yes,
through
sir.
the history.
So,
and other things that you look for on the monitor is whether there is gradual going up and going down of the heart rate or whether it is constant at a particular rate.
it was like at 180 throughout till I gave metoprolol, and then it came down to 150 and it stayed at 150.
Okay.
And not at all moving from there.
Because that would favor some kind of tachyarrhythmia a little bit more rather than it being a sinus tachycardia. Sinus tachycardia will have some kind of variation up and down.
So now we go on and take a proper history. Now here we go. Now, before that I just went on to do a focus for the patient. So the focus showed an IVC of less than 2 centimeters. And in mechanically ventilated patients, you don't talk about compressibility index, you talk about distensibility index. And the distensibility index for this particular patient was less than 18%, which showed me that the patient is no longer fluid tolerant. He may be fluid responsive, but no more fluids to be given, at least at this point of time. Lungs showing a bilateral A profile. Heart, there is no effusion. From whatever I could appreciate at a heart rate of 150. Please make sure that I'm commenting at it at a heart rate of 150 where I don't know what is happening. But still, it looked like a fine heart. I'm not commenting on the ejection fraction because you cannot comment on the ejection fraction with any tachycardia. But I'm like, fine, not that bad. And there was no evidence of any clots or anything. So after I do the focus, I go back and I ask the history for the patient, and the history goes like this. And apparently normal with no significant prior comorbidities. He developed symptoms since 10 days. Initially, he told that he was having a left-sided knee pain. Then it was followed to the right side, but still the pain predominantly was in the left side, which made him non-ambulatory for the rest of the 10 days. And outside, he was evaluated over the last 1 week. They took multiple x-rays of him. Unfortunately, I don't have the films for the same. They took it as a case of osteoarthritis, seeing that he's an aged and elderly male. Some specules also were present in the x-ray as well. And then they gave him some pain medications, not relieved. And ultimately, how do you manage osteoarthritis? It is TKR. And the indication for TKR is, you're like, the only indication for TKR is you have pain, especially for osteoarthritis. That is pain that is not resolved by analgesics. So then they referred him for PAC clearance, and PAC clearance began and was found to have some renal function that is deranged. And they found the patient to be anemic, and they received some transfusion support to maintain the patient here. Renal function deranged was in the ratio. I'll show it as the case progresses on. And here things starts to get a little bit bad because he started developing bleeding PR. For the bleeding PR, I did not find any papers or any evaluation as is the case with most of our patients. They don't have proper evaluation papers, or they might have lost the papers, whatever it is. But one paper showed that he had developed some bleeding PR for which multiple transfusions had been received. So this is happening since the last 7 days. All these events that we have been talking about. 2 days back, in hospital, he developed a seizure. the attenders were telling that they were informed from the hospital side that he had developed a seizure and that he has been having fever spikes since then. And I received the case during my night shift, so he was altered since morning. Right. So this is how the case scenario was. And this is how it basically went, shows that his total counts were on the higher range throughout the stay. As you can see, hemoglobin significantly dropped at the 26th of June. He might have received some blood transfusion during the time. You can see that his creatinine derangement increased over time. But from 26 to 27, it decreased abruptly because he received a session of hemodialysis at that point of time. I think they might have transfused him PRBC also at that time, which caused the hemoglobin to be 8.8. Some baseline thyroid function test was done, which is normal. CRP was insanely raised, but at least on the reducing trend or whatever you could say. They did an RA factor for him. Don't know why, but it turned out to be positive. A urine routine suspiciously found to have some pus cells, 10 to 15. And in this particular urine routine, epithelial cells was almost 0. And the number of pus cells on the very next day on the urine routine was 0 to 1 cells, which questions the entirety whether the patient did in fact have some sort of a UTI. Going on, the patients, he had done some ultrasound abdomen, which showed slightly enlarged liver with some coarse and aquatexture. CMD, like kidneys were grossly fine, except that he had some left renal cortical cyst. Outside, they had done an echo for some reason. I forgot to add that, and it showed that the RV LV function was good. There was nothing wrong. All valves were normal. Everything good. I know this might have been a little bit too much to be taken. So with all this history, what is your next step? We'll take a break for 30 seconds to 1 minute. See how you approach the case, how we'll assist the patient, and then I will say how I manage the patient, and then we can discuss as how I could have bettered the management. This is like a key point here, right? So if you want any clarifications, I'll just go. Right. Anyone wants to have a go as to how they would manage the patient?
बसवराज है, बसवराज से
हाँ बसवराज, चलो शुरू करते हैं. Baswaraj is not there, maybe.
Don't want to ask Junior because this might be a little bit above first sem.
This is definitely above
beyond first sem level.
This is beyond. I'm not expecting first semester.
Yeah. So. Arushi, you want to try what you would like to do?
So, एक बार focus findings दिखा देना बस.
Focus findings, nothing, man. These are the focus findings. You want anything more to be done with ultrasound? You want any more blood investigation?
Is there any RARV dilation?
No, nothing. Like it is very difficult to comment, but at least I couldn't find any RARV dilation. There was no clots as well.
In terms of investigations, they can get a CT done, CT head.
You want a CT head at this point of time? Yeah, I was planning CT head along the long term, but anything else to be done like around this time? CT head we'll eventually get, no issues. First, we need to come to a rough diagnosis as to what is happening with the patient. I have all the information with me if you ask them the right way.
That investigation chart.
That investigation chart, that is old chart. If you want the chart, I'll give it.
उससे आगे क्या था?
This is the old
Is
chart.
there anything else? Just this. The liver and everything was normal.
And liver was like mild, some coarse and echo texture. That's how that they told. How would you go ahead and manage this patient? It is simple. It is just a simple question. What else would you like to do to this patient after I've said all these things?
He's basically asking immediate next step, like what you want to do right now.
Any medication intake and chest
Medication intake
abdominal
during this
X-ray.
point of time, he received some IV antibiotics, some IV analgesics, received some levera for the seizure that he developed, and basically that's it. And blood transfusion.
They were planning for TKR, right? Any previous medications that he has received out apart from emergency?
No, nothing. Because as I told you, he has never been to a hospital beforehand. This was the first time that he was visiting the hospital as per the history.
Okay.
Nothing else. So I'll just give it a go. And then Mehul sir can add on to it. So we'll start from here. I've got a symptomatic patient from 10 days and it started with the left-sided knee pain. So the first thing that I'm going to do is go and check how the left knee is right now. Right. And he was predominantly telling that it is on the left side and not on the right side. Sorry. I just touched the left knee with my bare hands and I found that the left knee was definitely swollen compared to the right side. There was definitely some amount of warmth compared to the right side. There was definitely some amount of redness compared to the right side. Range of motion per se, I was not able to comment on it because I don't remember it adequately. I don't know whether it is tender because the patient is E1, V1, M1 at a heart rate of 150. So I went to check on that and I initially found that can this be a septic arthritis in this patient? It's the first thing that came to my mind because it is a swollen knee. An acute onset swollen knee with all signs of inflammation, you should always be thinking whether this is a septic arthritis. So suddenly my diagnosis is like forming in my head. So this is some sort of a septic arthritis with some sort of a septic encephalopathy can be the reason. It can be some sort of major sepsis where sepsis can infiltrate the heart, causing some kind of myocarditis, unreasonable tachycardia in the patient. Is the patient febrile was the next thing that I checked. I went and checked the temperature of the patient. It was like somewhere around 99.5, 99.6. So the diagnosis is already forming in my head. And meanwhile, we always want to check the blood gas of the patient. The blood gas, I'll just say it right now, the pH was 7.32, PCO2 of 33, a bicarb of 20, a lactate of 2, sodium was like 150, a chloride was like 109, showing some amount of dehydration, not sure. Potassium was 3, ionized calcium was 0.65. But I was not able to appreciate whether this was any QTC prolonged or anything at a heart rate of 150. I'm not sure whether I'm supposed to comment on that. And any potassium or ionized calcium, you shouldn't just solely believe just based on the VBG reports. You're always supposed to correlate it clinically. So all the electrolytes also didn't make sense. A sodium of 150 and hypernatremia making the patients in such an altered state, I don't think so it is possible. A potassium of 3 is supposed to make the heart funny, but a potassium of 3 isn't going to make the heart this much funny. A ionized calcium of 0.65 should actually make the heart can go into some sort of an arrhythmia, but it is usually something like a TDP, ventricular tachycardia, or a ventricular thing that was supposed to be happening. But this patient had a narrow complex tachycardia. So the hypokalemia and the ionized calcium that was reflecting in this particular blood gas did not reflect the clinical condition that he was in. So I ignored that part. The electrolytes were more or less fine. Lactates was fine. So the blood gas grossly looked fine. Coming over to our CBC, it showed that he had a total count of 54,000, which is neutrophilic predominant. He had a hemoglobin of 9 with an MCV of 109. And his platelets were somewhere around 86,000. So with this picture, again, it is like everything is pointing towards the sepsis. Raised blood count with a neutrophilic predominance. Thrombocytopenia can be associated with sepsis. It is part of the SOFA score. Hemoglobin of 9, we will talk that as the case goes on. So all this is forming in my head, like, can this be? So at this point of time, there is nothing more to do. I sent my, the sepsis panel, as we call it, blood cultures, urine routine, urine culture. So these are the things that are going through my mind. RFT, LFT is already sent, INR already sent. So these are the things that I said. I sent a peripheral smear also. Because a count of 54,000 was like too good. Can this be some atypical cells, whether I'll find in a peripheral smear? I just wanted to see. So I sent a peripheral smear also. And coming on to the real point as to why he had a left-sided knee pain, I immediately put my ultrasound to see if there is any increased fluid compared to the right side. Any increased fluid means that there's some sort of an effusion in there. There can be some active inflammatory thing that is going on. But on the ultrasound of the knee, it did not show me any significant fluid. But my clinical examination was too good that, I was like too much, seeing that he had all the active signs, I was like thinking that this had to be something acute over there. I went and did. I went, put on a sterile thing over the entire area and it withdrew some fluid. And the fluid that came out was frank pus, which was like almost confirmed my diagnosis. This guy has septic arthritis. I sent it for TCDC. I sent it for, and there's no role for TCDC actually. I sent it for culture. I sent it for TCDC also, nevertheless. Some protein sugar also I sent, the routine thing that we sent. So working along the lines of a probable septic arthritis with secondary systemic involvement was what I was thinking. Now, developed bleeding PR, I don't know why, but at this point of time, I asked them, is there any active bleeding PR in the patient right now? They are like, no, abhi to nahi hai. And the hemoglobin of 9 showed me that he's not actively bleeding, at least from my side. One episode of seizure, I was attributing it to that. Fever he had, I was attributing it to that. AMS since morning, I was attributing it to that. So with all of this in mind, this was what I did. Sir, Mehul sir, anything more that you want to add? Or if any of the juniors have any doubt, please ask. Any of the seniors, if they want any clarification or anything I could have done better, please ask.
About the bleeding PR, how long was the bleeding PR from?
Dude, I am not sure. They were like, see, he was admitted since 1 week, on and off bleeding PR to rehta tha usko. So he had received multiple transfusions regarding the same. And post hemodialysis, no more bleeding PR is what the attenders told me.
So etiology of the bleeding PR not known yet.
So far, not known yet. He'll need further evaluation for the same. But right now, it is not as concerning as to me as a septic arthritis. That's all. I'll keep it in the back of my mind. Mehul sir?
Yeah, so definitely the history and all is very much suggestive of sepsis. So immediate management would then be IV fluids and broad spectrum antibiotics and some paracetamol, just to see if the heart rate starts decreasing at least a little bit because of that. Then we can assume that it's not a tachyarrhythmia. I'd still be worried why he was having heart rate of 180. I understand that he's having sepsis, but since he was bedridden and all, I'll just still keep other things in mind. Archie said do a DVT scan on the chat box, so I would agree with that. Elderly patient, bedridden for 10 days. Keep PE in the back of your mind. Sometimes PE does rarely present with some kind of tachyarrhythmia. So PE can do anything. So we'll keep that in mind as well, even though this is basically just pointing towards mainly sepsis.
Accepted, sir. I don't think I did a DVT scan for this patient, and I think I'll take it into account the next time I manage this patient. Meanwhile, the recent report showed that he had some sort of a UTI. So I just wanted to make sure he doesn't have any other source of infection, maybe a pyelonephritis, you never know. I just put on the probe and I saw the kidneys whether there was any dirty air shadowing or anything like that to suggest a pyelonephritis, at least from my point of view, the kidneys looked good. Cortex, medulla well differentiated. And I think I saw the left renal, like some swelling there on the left renal region. I am attributing it to the cortical cyst that was mentioned in the previous studies as well. So no pyelonephritis. Perabdomen was soft. Auscultation, I auscultated the patient just to see whether he had any Krebs or anything. Chest was fairly clear. I went and did neck rigidity or anything, whether the patient had nothing. So basically, the patient, even though you have a clear-cut source of focus of infection, I just went and saw whether he had some other sources of infection as well. Whether it was lungs involved, whether it was some sort of a meningitis, whether it was some sort of an abdominal thing, perabdomen was soft, whether his the fall is that was draining clear urine, or whether there was pus in that. Did an ultrasound to see whether it was pyelonephritis. So grossly looking for other sources of infection as well. One or two points I want to highlight here is, especially when you're managing sepsis and not septic shock, you want to give IV antibiotics after seeing what is the probable source of infection. Whereas in septic shock, you are not clear, you just hit with a broad spectrum antibiotic because the patient is too sick. But in sepsis, I gave it a good time, and then is where I gave the antibiotics. And especially this is true when you're thinking of septic arthritis, because whatever textbook that you read, a patient with septic arthritis should always be aspirated before giving antibiotics, because antibiotics can reduce the yield up to 50 to 70% of the time. So this is one thing that I knew, which is why I withheld antibiotics despite the patient being this sick, I know, till I aspirated the fluid out. And then I gave him the broad spectrum antibiotics, seeing that as far as I am considered, the patient is not yet in septic shock, but definitely in deep sepsis. So 2 points here. Septic arthritis is one area where you really have to give antibiotics if the patient is not that much sick, only after you drain some fluid out of the fluid. And the next thing is what antibiotics. So for that, you need to know that most commonly septic arthritis is going to be a monoorganism, and that it is mostly going to be an MRSA most of the times. So what you need to do is cover for MRSA, and the drug of choice would of course be vancomycin. So that is what I gave this patient. So what are the other antibiotics that you should be thinking of? Young adults who are sexually active is what the textbook said, presenting to you in this kind of picture, you should be thinking of gonococcal septic arthritis. But there's a huge difference in how gonococcal septic arthritis and non-gonococcal septic arthritis presents. Septic arthritis is an acute event. You will have tenderness, this thing, over a short period of time. Non-gonococcal is going to have a prodromal phase, low-grade fevers, SSA, it will have some sort of a subacute course. So that is one thing. It is rarely going to be found in patients who are not that sexually active, number 2. So that is as far as gonococcal septic arthritis go on. And if the patient that you're managing has some sort of sickle cell anemia, they say that salmonella infections are, the chances that it is going to be infected with salmonella is more. I don't know the reason precisely behind it. It says so in the textbook. And you're going to be covering that with ciprofloxacin 400 PD. So that is how much a septic arthritis goes. Just a brief overview on that. It is mainly like what antibiotics do you give? Yeah, there are 3 types. An acute event, you are supposed to give vancomycin. Does the patient have risk factors? That is, young male, sexually active, you have to think of gonococcal. You are supposed to give a ceftriaxone 1 gram stat dose. And if the patient has some underlying sickle cell anemia, you're going to think of salmonella, and you're going to give a ciprofloxacin as well. So that is how you're roughly going to manage this patient. So this is a very important point, and the entire point of this presentation was to just introduce to the second sem and third sems about what septic arthritis is, how you're supposed to do, what are the risk factors associated with various other infections that you're going to do, and how and when you should be giving these antibiotics, and what are the first choice of antibiotics. So if that is clear, we'll just rush through the case and we'll just move on to the next thing, if no one has anything else to add or any more doubts. And if I'm being too much speedy, and if you want me to repeat the whole thing again, please tell me. I'll repeat it at a much slower pace.
So why do you think the patient had seizure?
Again, sir, the question is whether the attendee saw the seizure. It was just documented on the paper. If you're supposed to believe it, the patient had went to go seizure. I am not sure. So again, going on to why the patient had developed an altered mental status in the first place, I would go on to my favorite mnemonic, that is the MIST, M for metabolic causes. Electrolytes were pretty much normal. He had a raised creatinine outside, so uremia can be one of the metabolic causes why the patient is altered. Number one. Infections we already talked about. Less likely to be meningitis, but still it needs to be given some sort of a consideration. Number two. Any structural causes. I want to do an NCCT for this patient to see what happens. Or any bleed that might be happening to the patient or whatnot or what else. I don't know. I'm going to do an NCCT for this patient. And toxins, very less likely. But just because I wanted to complete how I manage a patient, I went and did a urine tox for, I don't know why, but still I just went on and did a urine tox. So that is my approach to an AMS. I still don't know if the patient develops seizures.
But it would be unusual that patient is having organ sensorium due to this thing, septic arthritis and sepsis, but the GCS ends up as 3.
Sir, I agree with you wholeheartedly. I don't know what is happening to the patient. I want you to shed some light to it, if you can.
I'm assuming you must have done imaging for that, obviously.
The case is a mystery, sir. I agree that the case is a mystery. I just wanted to bring this case because I just wanted to introduce about septic arthritis more than anything else. And just how to work up a case for the first semester. That's all. Nothing else. 1 or 2 ECGs. That's it.
Well, could be some multi-system process involving both the arthritis part and probably CNS, maybe.
Yes, sir. I agree.
But it's the kind of thing that will need evaluation over days or weeks, maybe. Not something we can do in a few hours.
The only thing we can do in a few hours, maybe a CT and get it done with. And the emergency management stops. So here we go. We go on to have our CT. And this is 1 hour post intubation. The patient is still even VTM1, pupil sluggish reactive, bilateral plantars mute, dorsal negative, corneal conjunctival, gag reflex, everything negative. The patient was giving spontaneous breaths. No necrogenicity or any other meningeal signs. Although the only point that I would like to take from this is the patient is immediately post intubation. You are not ideally supposed to comment on all of these things immediately post intubation, especially since the patient has some amount of renal dysfunction, and that for all the rocuronium to be out of the system, it will take quite some time. So you're not supposed to actually do all this. But I'm just telling this is how you should be assessing a patient who is even VTM1. You should be checking their plantars, you should be checking their pupils, you should be checking for brainstem reflexes, which are your corneal conjunctival gag reflexes, your dorsal reflexes, whether the patient is spontaneously breathing on a venti. So these are signs. I think we'll discuss this in much detail when we talk about how to approach or how to confirm a patient who is brain dead or neurologically brain dead, as they say. So this might, I think we'll discuss it at some other point of time, sir, and we'll just move on with the case forward.
Definitely.
Yeah. So this was how I was thinking. Septic NCAF, maybe, I'm not at all sure. I need a CT to be sure, or myocarditis, AK. And further events. A urea of 163, uremia can be the cause, not sure. A creat of 5.3. Here the serum calcium comes out to be low, a 7.4 with a serum albumin of 3.5, showing that the patient was indeed hypocalcemic. Sodium potassium was within normal limits, LFT within normal limits. Urine routine came out to be normal. Peripheral smear shows neutrophilia with shift left. Macrocytic cells can be attributed to the patient having an MCB of 109, and this NCCT comes out to be perfectly normal. No surprises as far as the lab investigation goes, is what I would say. And then I see the patient for the next night shift, and this is his ECG. Anyone wants to have a go?
So big is here. He can take this one.
So big. Chalo. Souvik is not here.
Hello, sir. Good afternoon, sir. Sir, I just joined. Good evening, sir. I just joined.
It is good, man, because it doesn't make any sense, the case from starting to end. So you can enter at any point of time. I just wanted to comment on the ECG, nothing else.
Yes, sir. Sir. Sir, can you repeat your question? I don't know.
No, just read the ECG. That's
Just
all.
read the ECG findings. What do you think, boss?
Sir, this is a 12-lead ECG with standardization.
Right.
Can see grossly this ECG has I can see some P waves and QRS, narrow QRS complexes in V1.
Right.
But
Great.
And V2, V3, V4, V5, V6, there are some huge large T waves, as I can understand, the large T waves in V2 which are not appreciable from and the QRS is merging into the T waves from V3, V4, V5, V6 more
Right.
appear to like a broad QRS complex and probably it could be hyperkalemia with some sine wave changes.
Hyperkalemia with some sine wave changes. Excellent DD. Souvik, any more DD you want to add other than a hyperkalemic changes?
So, have you given out some history of this? Since I just joined.
No, nothing, man. You just have to read the ECG, nothing else. It is just an ECG that is showed to you. Hyperkalemia is, I would agree 100% with you. This can be hyperkalemia.
Could be some acute coronary syndrome presenting with some broad QRS complexes with might progress into some electrical instability kind of presentation.
So what do you call it?
VT, acute coronary syndrome with electrical complication of the VT.
Okay, so the next differential that you would like to tell us, can this be a VT, right?
Yes, sir.
It can be VT. Anything else?
But the only finding that's going against this is there are some leads which shows normal changes. So some problem with the ECG maybe. Just
right. So you told about hyperkalemia, you told about VT. Anyone else wants to add any other differential?
Tombstones.
That's it. Mehul sir, please explain the ECG.
Yeah, I think so. Because on the right track at the end, he was saying something about a few leads not making sense, but that is a clue here.
That is the clue.
You go to V1, you are seeing what the actual QRS complex is. It's quite narrow, and you can see normal sinus P waves actually in V1, and very clear normal biphasic P waves that you usually see in V1. So in V2, we are seeing actually massive escalation. So it's huge. And the leads below that is actually most of that is actually due to the escalation. So it's actually completely towering over the QRS. So you immediately, if you are only looking at one or two of these leads, you might think it is hyperkalemia or a VT or something. But when you're looking at the entire ECG, that's when it actually makes sense that okay, this is actually massive escalation, and it's there in anteriorly V1 to V2 to V6, and also 1 and AVL. Actually the leads are not labeled properly in some of.
So it is AVR, AVF, and AVL from up to down.
Okay. So you're seeing escalation in the most of the leads actually.
Exactly. I saw this. I was shocked. Is this is like, I hope no one has any doubt. This shows that anterior wall STEMI, lateral wall STEMI, inferior wall STEMI. And I was like shocked. So let us just come back. And my doubt to my seniors is, was this an hyperacute T wave that I missed, that progressed on to a full-blown STEMI?
Actually, even I felt initially on seeing this ECG that TVS and at least in the anterior leads definitely look hyperacute.
Definitely
But-
look high.
But it's very difficult to comment on it when you're having a possible tachyarrhythmia on top of that.
Exactly, sir. Because I'll tell you the truth, I thought whether can this be a hyperacute T wave also at that point of time. I had done an ECG over 45 minutes apart, which showed the same changes, which I thought like if it was a hyperacute T wave, it might have evolved by now as what I thought. I am not sure to this date whether this is the hyperacute T wave that you're talking about, and whether I missed it, and whether the patient went in for a frank STEMI. But a STEMI like this cannot be explained by any means, sir.
Definitely.
Definitely. And at this point of time, so this is from this point is what I did. I went to sleep. I came back for the next night shift and saw the patient like this. Just put on my echo probe and the heart was beating like this. And they did a drop at that point of time. It was like more than 10. And you know the outcome here, right? The patient went on to die. So, an unclear case. What did we learn? We learned 2 ECGs. We learned some septic arthritis. We learned some approach to AMS. We learned even if we have a clear-cut source of infection, we are supposed to look for other sources of infection. We learned how to assess not just the numbers, but clinically assessing the patient is most important. That clinical gestalt and clinically appreciating what the patient has makes a lot of difference. And those are just the points from this case that I would like to highlight here. The entire case does not make sense whatsoever. And with that, I would like to just end my presentation. Because I think it has taken, exactly 1 hour since we started. I don't want to.
I think we have Sridevi ma'am and Pradhiman sir with us. So we just wanted to wonder if they have any other thoughts on this case. Sri Lakshmi wants to ask something. She can ask. You can unmute yourself and ask.
So actually, I was thinking, could we have shocked the patient in the first instance, altered mental status and unstable tachycardia, and then consider a repeat ECG?
I
Would
would
that have made any
Definitely,
difference?
that
100% I would agree with you.
definitely, and you'll be doing it by the book only. So it's you are definitely justified if
You're definitely justified in doing that. I'm not sure whether it would have resulted in a different outcome because I did not do that. I hope, Sri Lakshmi, I hope that is your name. I hope that you're justified. I mean, I hope you're happy with the justifications as to why I did not cardiovert this patient.
So actually, altered mental status need not necessarily because of septic shock or uremic encephalopathy. In any patient who is having unstable tachycardia, we can consider shocking is what I think. And
I
I'm not
100%
sure.
agree with you. I 100% agree with you. That's all.
Yeah. Okay.
No, I just want to just give you an idea as to, are you like at least 30% satisfied with the reasons as to why I did not cardiovert the patient? No.
Altered mental status, I mean, I consider that would be an indication to shock the patient. That was the only thing. And when looking retrospectively, that it could be a missed STEMI, and would shocking the patient make a difference?
Not sure shocking the patient would make a difference to the ultimate outcome. But you can definitely say that it was a very definitely a viable second option. And you would definitely nobody will say you are wrong. And Kuttan's reasons, the way he explained it, does make sense from his point of view. He was feeling that altered sensorium is not actually due to the uh, ECG rhythm per se, based on his clinical evaluation. So, but generally, I do feel that it's my personal opinion anyway that if you're having any doubt, should generally have a low threshold for electrical cardioversion.
Then, sir, I agree that. No doubt.
But sorry to say that I am not sure how I can add too much because a lot of these things are not actually making sense.
Not me.
So why a patient with sepsis ended up being M1?
M1, that is the biggest thing.
Yeah,
That's the biggest thing.
that I'm not sure. So the patients were very sick and all. Sometimes they can develop Takotsubo, and Takotsubo can present with escalation that will be very similar to STEMI. So that is one possibility that I would like to throw out here. And it's like impossible to differentiate the two unless you take the patient to the cath lab. So that is one possibility. But another thing is that some patients, they can develop an MI anytime. He's a 69-year-old guy. So this anybody who, beyond a certain point of age, they can have develop an MI at any point of time. It happens that patients are admitted for one reason, then they end up having a STEMI in the ward. So these things are not unheard of also. So generally there is something called Hickham's dictum, I believe, where it says that patients can have as many diseases as they please. So I think this particularly holds true more for elderly patients, so they can have multiple things going on. If you have a 20, 25-year-old patient, it's more likely that the multiple problems are being caused by a single underlying pathology. But once you're in 69 years, it's quite possible that he was having multiple different issues at the same time. At least that is my way of trying to make some kind of sense of this. If anybody else has anything to comment, and they are more than welcome now.
Stop the recording then.
Yeah.